Well, good afternoon, everybody out there in sudden arrhythmia death syndrome Facebook live land. Welcome, July 10th, episode number 21. Believe it or not, for those of you who have joined us since we first started doing these when the COVID-19 pandemic came upon us. So I hope you all had a wonderful 4th of July weekend and celebration and time, special time, staying socially connected, albeit perhaps still physically distanced over the 4th of July weekend. Thanks for joining us. I'm Mike Ackerman. As you may know, I'm a genetic cardiologist at Mayo Clinic in Rochester, Minnesota. I'm not there now. I'm on vacation. Woo! And I have an hour to go, and then vacation really begins. But I'm also the president of the board of the SADS Foundation. And on behalf of Alice Laura, our CEO, Aaron Waite, our producer for SADS Facebook Live, thanks so much for taking the time out of your day and being part of the SADS Facebook Live community. And it's great to have you. And as your questions start coming in, I look forward to going over them. I do have some news for you, some exciting. So we've had exciting news in the life of Mayo Clinic and our genetic heart rhythm program there earlier this week. My latest PhD student, Carrie Turkowski, successfully defended her PhD thesis on the genomic architecture of long QT syndrome. And so congratulations, Carrie. And then later in the week, we just had a Mayo milestone of I had seen our 4,000th patient, 4000, over my career there at Mayo Clinic. And each of those patients and each of those families represented by those patients are truly special. That included over 1,000 patients who came with a diagnosis of long QT syndrome or a different genetic heart disease and were in fact dismissed as normal. So whether they came and we had to tailor their therapy for a true sudden death predisposing disease, or whether they came thinking that they had one and they left without the diagnosis, without the disease, and sometimes without the defibrillator that somebody had implanted elsewhere, all of you have been precious to us, and we're grateful that you have placed and did place your confidence and trust in Mayo Clinic and our program. So thank you for that. Now, a low highlight. This is a really low, I must say. We broke a record yesterday in the United States. Yesterday's record broken, the most cases of COVID-19 in a single day, 63,000 plus. This is ridiculous. We've crossed worldwide 12 million, over 500,000 deaths. The United States has 25% of all cases and all deaths at 3.14 million and over 133,000 deaths in the United States. In our campuses, Mayo Clinic Rochester, fortunately in Rochester, we've only had 1,200 cases and 18 deaths. Not so in Mayo Clinic, Arizona, in the Maricopa County of Phoenix and Scottsdale. Very hot there right now in terms of viral spread, 73,000 cases, 1,000 deaths. The Mayo Clinic Jacksonville campus, nearly 12,000 cases, 74 deaths. And one of the hottest areas right now is Houston, Texas, Harris County, over 40,000 cases there. There's a silver lining, though, in that the death rate from COVID-19 in all of those places mentioned is now just at or just above 1%. So way lower than, remember, what we were hearing back in February, March, or April. But we've got way too much spread going on. We are not, as a country, doing a good job of socially distancing. We've got to get our game back on because this is going to continue to rear its head in a big and bigger way during the rest of the summer and fall. Now, questions are coming in, and I'm going to get to them because these are some good ones. And I must say, I loved last week. Your questions were awesome. And I know this week We teased you. You thought you were going to see me interviewing one of my most favorite people in our field, who I think is the king of long QT syndrome, Dr. Peter Schwartz in Italy. Well, he had to cancel. He notified us yesterday. He forgot about something. Their anniversary, his and his wife's, of now many years. I won't say how many. So happy anniversary, Dr. and Mrs. Schwartz. Well, actually, Dr. and Dr. Schwartz. And I hope you had a wonderful celebration this evening. But guess what? I'm interviewing Peter, Dr. Schwartz. Mark your calendars. July 31st, 3 weeks from today, at an earlier start time because he's in Sardinia, later time zone there. So at 11 a.m. Central Time on July 31st. I'll tell you about next week's lineup too, because next week's is going to be great. But before I take a couple questions, let me, I forwarded to the SADS Foundation something that I saw really helpful that Mayo Clinic has provided, which is some debunking COVID-19 myths, because there's a lot of them out there. And anytime the cases start spreading and the numbers start increasing, and Dr. Fauci says it's not unlikely that we could see ourselves hitting 100,000 cases every day in the United States if we don't get our act together. And so with that, all kinds of fear comes in, all kinds of myths propagate, and all kinds of remedies that don't work start spreading. So here are a few of them. There is no data that the flu vaccine, the pneumonia shot helps with this. Zero, none. Get your flu shot this fall, though. Influenza didn't disappear and won't disappear. Be sure to get your influenza shot. Number 2 myth, squirting your nose with saline doesn't help. Don't bother. Waste of time and money, and it's annoying. Number 3, that high temperatures, so baking it out, will reduce it. It doesn't. This virus can coexist in hot temperatures and cold temperatures. So this notion that just taking a hot bath will prevent you from getting it is ridiculous. Taking a hot bath is comfortable. Enjoy the bath, but it's not going to do anything for COVID. Low temperatures, it can exist in the cold as well. That's a myth. Antibiotics, they don't work for it. Now, if you get bad COVID-19 and you get a super infection, the doctors might have to use antibiotics for the superimposed bacterial infection. Stop. Number myth. Next one. Everybody stop spraying your bodies with alcohol and chlorine. It doesn't kill the virus. It won't prevent it from entering your body. So people are spraying their clothes with chlorine, spraying their bodies with alcohol. And worse, people are drinking alcohol. Now, that might be for other reasons out there, but drinking alcohol does not protect you from COVID-19. In fact, one of the reasons for the rise in cases has been the reopening of bars where people are drinking alcohol in closed spaces, crowded people, mask not on, hard to drink with the mask on, and cases are happening there. So you might be choosing to drink alcohol for other reasons, but it's not protecting you from the virus. Next myth, garlic. I like it. It's great on pasta. We're having it tonight. It doesn't protect you. UV lights and lamps won't disinfect you from COVID-19. Conspiracy theory out there, those 5G mobile networks, maybe it's running through the networks. No, not, nope. So the viruses cannot travel on radio waves, on mobile networks. Countries without 5G have it, just like countries with it. So scrap the black helicopter 5G mobile network idea. Disinfectants, they work on the surfaces, use them, but not on your body. I'm hearing people wiping the wipes on their arms and stuff. Stop it. Doesn't work. And then you're spending a lot of money. People are spending a lot of money on zinc and echinacea and all these things. Not bad for the immune system, perhaps, doesn't work for COVID-19. And the supplement, the snake oil supplement that's out there right now is colloidal silver. It doesn't work. So, my friends out there, the things that work are the things that we've been talking about from day one. If you look back at our program, Physical distancing, the 6-foot rule, stay apart, washing your hands with 60% or more alcohol-based solution for 20 seconds, hot water. The virus doesn't like this. Do not touch your face. And if you're going to touch your face, have washed your hands with the 60% solution for 20 seconds before you do. And people, this is not a red mask or a blue mask. This is a mask. Wear our mask. I wore it. My wife and I wore ours when we went to lunch just before this. We had lunch at a restaurant, outdoors, nobody around. So we're not eating indoors in indoor restaurants yet, but we are doing takeout and we are doing outdoor restaurants. And after the waiter leaves us and the meal comes, the mask goes off and we enjoy lunch. And we had a great lunch. It's my wife's birthday tomorrow. So we had a little birthday lunch for her before all of the kids come. So that's a little bit of an update and on COVID-19 and things related to it. And now it's your turn. And Carrie, hello, and Deanna, it's great to have you again. I think you're going to be our regular, and I can't wait to have you in medical school and residency and fellowship. And who knows, Deanna, maybe you're going to be my partner someday. And SADS Foundation reminder while I'm looking over Susanna's question, and it looks like a good one, but it's going to take me a while to glance through it. Reminder, there is the SADS Foundation communication survey. Would you go to the SADS Foundation website, www.sads.org or stopsads.org, whichever way you want, it'll get you to the same spot. Click on the communication survey. 80 of you have filled it out already, and you're giving us really helpful suggestions as to who we are as the nonprofit advocacy organization devoted to families with genetic heart diseases, lifelong QT syndrome, Brugada, CPVT, and so forth. And so this is very helpful to help shape our future together. So thanks for that. Courtney, I hope we started covering it, Courtney, as you're wondering what on earth is going on today. So those were the first 10 minutes of going on, and the rest is your questions. And here's one, a short one. Remember the rules. You can help me out. If your question is pithy, word of the day, that means short, succinct, brief, to the point, that helps me to digest it quickly and see if I even have the synapses to process it on the fly and answer it in some sort of meaningful way. So Evan, you did a great job. Evan's wondering whether your patient's EKGs reflect an improvement once they begin to use beta blockers, or another way of saying is, how do you decipher if things are being controlled on the beta blocker? Fantastic question, Evan. It serves at least for long QT syndrome and CPVT. The way I like to think about beta blockers is your long QT mutation is the fuel. It's the substrate. And fuel never will be a problem unless fuel gets ignited by sparks. So fuel plus sparks, explosion. That's the arrhythmia. That's the long QT signature event of torsades that then causes torsadogenic fainting, seizing, or tragedy. And so the beta blockers, for the most part, do nothing to the fuel. The fuel is still there. It still has whatever its flammability index imparted by the mutation in the host. But the beta blocker sort of puts a flame retardant or a spark retardant around the fuel, making it harder for the sparks, adrenaline, to reach the fuel, to ignite the fuel, to cause the explosion. So beta blockers work really well in long QT syndrome, really well in CPVT as sort of the spark retardant, if you will, and not a flame, not a fuel. It doesn't change necessarily the flammability of the fuel. So that means that in most situations, you will not see the QTC shrink on the EKG. It doesn't make the EKG look better. It doesn't make the QT look shorter. Now, that may be partially true, as there are some situations with some beta blockers where we may actually see the QT number get a little bit better. So we don't use the QT number shortening to tell us that we have a good dose of the beta blocker in the system. We usually dose the medication to get it to a decent dose in the system by how big or small the person is, and then we put you on a treadmill stress test and see what was your maximum heart rate before your body was on beta blocker, and now what is your maximum heart rate on the beta blocker? And have we decreased that maximum heart rate so that we know that there is a measurable amount of beta blocker circulating in the system? So we dose it in part to see that shortening of the heart rate on the stress test. And we also honestly dose it to try to get to a decent dose before you start hating us with beta blocker associated side effects. So it's a balancing act with that. And Evan, thanks for that question. And you kicked us off in our question session. And I'm going right down the line to Beverly. Hi, Beverly. Is it possible to have a de novo mutation for KCNQ2 VUS and seizures and not be long QT related? The cardiologist dismissed us as neurological seizures. Oh, that's a loaded question, Beverly. It's a good one. A couple things. The gene KCNQ2 is not a heart gene. It is not a long QT gene. KCNQ1 that's LQT1. And the gene KCNH2, that's a long QT gene, that's LQT2. So the KCNQ2 channel is principally a neuronal potassium channel. So your cardiologist may be well spot on about that. I'd have to know a lot more details. Catherine, do we have LQT3 patients, and specifically R1623Q as the sodium channel mutation, who experience migraines, dizziness, not medication related? Really, really good question, Catherine. So LQT3 is the third most common subtype of long QT syndrome. About 5 to 10% of all of our families have type 3 long QT syndrome. That's due to mutations in the sodium channel, and the gene is SCN5A. Catherine's specific mutation, R1623Q, was one of the very early mutations first reported 25 years ago in 1995. There are exceptions to what I'm about to say, but that mutation tends to be a more severe one. And so we know a lot about that mutation, about its behavior. It tends to cause irritability in the heart's QT system, sometimes very long QT intervals, but it can also annoy the heart's Purkinje cells and cause rogue beats or extra beats or premature ventricular beats, but not migraines and dizziness. So I have not seen that. I take care of a lot of families with that specific mutation. The challenging thing with that and that symptom, Catherine, is that dizziness is a really common symptom. About 10% of all people complain of dizziness. So that means 10% of all of my long QT patients get to complain about dizziness. Migraines is a common headache entity, and it's somewhere around 5 to 10% of all people suffer from migraines. So we're going to have the coexistence of those two entities. And I've never, ever been impressed that migraines seem to be tracking at a higher frequency in our long QT patients. We could look at that a little bit more closely, but I've not ever seen or felt a signal there. So I don't think that's going to be the case. I was just starting to read, and my future doctor, Dana from California, was wanting to share some great news. Found a cardiologist. That's great. Uh, um, All I can say is you're in great hands there, and give a big hello to Dr. Marco. He's a good friend of mine. So I think you're going to be in great shape. And if he has any concerns, Marco has me on speed dial. So I think you'll be just fine over there. Um, so Victoria, hello, Victoria. The notion, yeah, of reading through. Oh, I think a great question Victoria has. It's a long one. So remember, it's hard for me to read and do at the same time, so making them shorter. She was quite ill in December and January. Well, December has nothing to do with the Wuhan virus or the CoV or SARS-CoV-2 out of Wuhan, China. Let's get that straight and let's debunk any myths. In fact, I have a funny side story. My wife was at a grocery store here in near Green Lake, Wisconsin, Markesan, Wisconsin. She, after a couple times there, being the only one wearing a mask, she asked the clerk and said, I've noticed that I'm the only one wearing a mask. And the clerk was just kind as can be and said, "Oh, we don't really have to worry about that. It came through here in November." So now we all know that this virus actually didn't exist or didn't originate in Wuhan in China. It actually originated in Markesan, Wisconsin. So just to show that there's no shortage of ignorance everywhere. So it wasn't here in December. It certainly wasn't at Mayo Clinic in December. And about the antibodies, well, antibody development really wasn't available. So it's hard to test for antibodies when they weren't available, Victoria. So you just have to remember we're in a rapid evolution of knowledge, of technology. And I think I share your question, when is testing going public completely and not just hospital staff? Well, it's already moved past hospital staff, Victoria. So, for example, on many hospitals, on many campuses throughout the United States, if you get admitted, just like at Mayo Clinic now, every patient being admitted to the hospital at Mayo Clinic gets tested by PCR and by antibody testing to find out, do they or do they not have it before they come in, so that if they are an asymptomatic shedder, potentially we know of that, so we can proceed with their elective knee replacement surgery or whatever under appropriate quarantine. And we also then test them 18, 2 or 3 weeks after they're dismissed to show that they did not get it while they were in the hospital. The hospitals, most hospitals, few exceptions, are still incredibly safe places to be. I'm not aware of any patient to physician or physician care team to patient spread on our campus for the last 3 months, as an example. So we need people who have other health issues to be seeking care for all of their health issues and not staying away from doctors and hospitals out of COVID fear and then end up dying from their neurologic disease, their cancer disease, their other heart condition, and so forth. So, will we have universal antibody testing for the public? I don't know. I'm not going to make a prediction. Technology is rapidly advancing, that's for sure. Michelle's question, does one need beta blockers if they have an ICD in acquired long QT syndrome? Generally, acquired long, I love that question, Michelle. Let me break it up in two parts. One, most patients who get an ICD because they have congenital genetic mediated long QT syndrome better have gotten the ICD for a good reason. Most patients don't need an ICD. Most. Less than 20% of all of my patients have an ICD if they have long QT syndrome. Most don't need an ICD. If you have it, maybe that means that you already did cardiac arrest or you have a bad version of your long QT syndrome. In that case, you probably are going to be on beta blockers as well to make it less likely, because after all, the ICD doesn't prevent anything in the sense of if the fuel and the spark happen, the explosion will happen. The device will not do anything to prevent that. What the ICD does is after the explosion, it's the fire extinguisher. It puts out the explosion. It returns the heart rhythm back to normal pronto and prevents tragedy. So it does prevent something, tragedy, but it doesn't have any say in whether or not the explosion will happen in the first place. Now, if by acquired long QT, Michelle means my QT is long, not for a genetic reason, but for an acquired reason. It's long because I was on drugs, medications, prescriptions, which prolonged my QT interval, and it prolonged it so much so that I did drug-induced sudden cardiac arrest, and somebody had to defibrillate me and revive me, and then got a defibrillator implanted because of that. Most of the time in that setting, we don't need a beta blocker because beta blocker isn't going to be the protector like it is in congenital long QT syndrome. Removing the acquired sources of the problem, correcting those is all that's necessary. And sometimes we would not even have to put in a defibrillator if we had identified what were the reversible causes of that QT prolongation. So that's acquired. Todd, I'm sorry about your colon cancer diagnosis. You're going to do great with it. Survival outcomes in colon cancer in 2020 are fantastic. I'll just trust that it's been caught at a good time for you. You're going to be on cancer therapy. You will be victorious. You'll conquer it, Todd. Most cancer drugs, and his question is what about these cancer medicines, and will they bother the QT interval? Your doctor should do what you do and refer to the website www.qtdrugs.org or crediblemeds.org, takes you to the same place, or the SADS Foundation, which has a direct link to the drug list. All drugs, FDA approved, that have a QT prolonging signal to them are on that hit list. And so they could search that and look. Many drugs used in colon cancer specifically are QT safe. There are some cancer drugs, they're in a class of drugs called tyrosine kinase inhibitors that are potentially QT prolonging. But it's easy for your doctor and your healthcare team to navigate. Just point them to that list of medications, and you're going to do great. Eve, hi Eve, one of our regulars, and I always love it when she's joined us. Beta blockers better for asthma. So like migraines, like dizziness, there is about a 7 to 10% coexistence of long QT and asthma because about 7 to 10% of us, I'm a fellow asthmatic, pretty mild now, funny asthma story maybe for another day for you, but will have coexisting asthma. Long QT didn't create the asthma, not at higher risk of asthma because of long QT. You just have a 1 in 2,000 disorder called long QT syndrome and a 1 in 10 problem called I have asthma. So the two will coexist, and indeed about 7 to 10% of my 1,400 long QT patients have asthma as well. Now, most of the time, my most favorite beta blocker, which is atenolol or propranolol, which are asthma bothersome for some, work just fine. In other words, many asthmatics can stay on beta blocker therapy without it aggravating your asthma. You need to work with your doctor, check how severe is the asthma. But if your asthma is, I need my albuterol inhaler once in a while, I actually don't know the last time I took the inhaler, almost always we can stay the course with the beta blocker of atenolol and propranolol. If we're a brittle asthmatic where we're getting oral steroid 5 days of therapy, and we're doing that a couple times a year, and when I take my beta blocker, I can tell my asthma is worse, then for that long QT person with that kind of asthma, we have to come up with a non-beta blocker option. I do not move you to atenolol. Atenolol is a beta 1 selective beta blocker that bothers the airways less, but I hate that beta blocker from a protection standpoint. I do not think, Arthur Wilda does not think, Peter Schwartz does not think, Sylvia Proyer does not think, Susan Etheridge does not think that atenolol is as good of a spark retardant, like we talked about, as the others. So I will not switch you to atenolol. If I have bad long QT and bad asthma, we are starting to think about using and doing left cardiac sympathetic denervation surgery as the beta blocker substitute, so that then we don't use uh, beta blocker at all. Um, so Beverly clarified. So yeah, great, Beverly. So Beverly's question, remember she asked about KCN H2Q2. It's actually H2, her family's gene. So she has de novo LQT2 and some seizure activity. Almost for sure, and I'd have to review things, of course, Beverly, but if your LQT2 variant, if they're calling it a VUS, a variant of uncertain significance, but it's de novo, meaning it started new in that person, not in the mom, not in the dad, but after conception, that de novo variant is almost for sure an LQT2 variant, no matter what the company calls it. So the genetic test company might have had to call it a VUS, but it's probably not. Now, we have many examples of LQT2 patients having a higher frequency of concomitant seizure activity. And there's an interesting scientific story behind that, because the LQT2 gene is also expressed in the brain, especially the hippocampus and the temporal lobe of the brain. So we have examples where we have LQT2 patients who are having true cardiac seizures from long QT explosions, but are also having true neuroleptic or neuroepileptogenic seizure activity when their heart is in perfect sinus rhythm. So it requires a careful evaluation from both your long QT cardiac doctor and an epilepsy specialist to try to figure out which part is misbehaving. Is it the brain or is it the heart, or sometimes both? So best wishes with that. Stephanie's wondering, is atrial fibrillation more common in people with long QT syndrome? Yes, it is. It's a great question. We published that over a decade ago now. Atrial fibrillation as we age is an adult onset disease. So in 60s, 70s, and 80s, atrial fibrillation becomes more common, especially if you have high blood pressure, especially if you have obesity. Now, healthy, slender, long QT patients, we do see a higher frequency of early atrial fibrillation than the general public. It's not super high at all. So we probably see atrial fibrillation in 1 to 3% of our long QT patients at young age. So I think there is a connection there for long QT and earlier onset atrial fibrillations. Hi, Mary. Can the high temperatures cause problems for long QT1? Not really. We tell everybody to lower fever. That increase in core body temperature could be long QT irritating. It's unlikely to be so, but lower it anyway. We think that the hyperthermia long QT connection may be mostly LQT2, but so overall, not really. Debbie, I'm sorry, Debbie. So Debbie's son passed away at 27 from a SADS condition. His daughter is now 10 and is experiencing, so your granddaughter, Debbie, and experiencing very high heart rhythm and episodes of dizziness. Should we be asking to see a cardiologist and now being referred to a neurologist in the UK? That symptom complex, Debbie, in your granddaughter is really common in 10-year-olds, usually almost always normal. So I don't think, please don't hit a panic button yet. But I think it's time, if your granddaughter hasn't been carefully evaluated by a heart doctor in UK, to probably start that process. Start it in sort of with due discipline, but not with anxiety. There's just no need to be anxious. Just let's get it checked out and let me know. Um, Jesse is coming to us, and we're at, oh my goodness, 5 minutes to the top of the hour already. Your questions are amazing. I love these. I hope you're enjoying these. It's worth using an hour out of my vacation day, even though the lake does look special at the moment. No, I love these. Your questions are great. So we'll do a couple more. From Germany, Was machst du heute Abend? That was my one phrase I learned in my German class in college, Jesse. Um, I think it means, what are you doing this evening? And then the answer from the class was ins Kino, going to a movie. But um, um, that's my German. I didn't get a great grade in that one, A minus. Uh, and she has CPVT. She's on propranolol. I like it. Low dose of flecainide since April. I like that a lot. I like combination drug therapy for CPVT with a beta blocker, propranolol or natalol. I like them both. And flecainide. I like that one a lot. Feeling weird feeling in the chest, about to pass out. Nope. And wondering, is it having anything to do with the CPVT? No, no, no. I love the question because it's asked so often, Jesse. CPVT and long QT don't give feelings in the chest that are weird and almost passing out, but not passing out. That's almost never. That what you described, on the other hand, is something that we see every week in the clinic in healthy preteens, teens, and young adults. It's just an incredibly common symptom complex that is completely benign. So really has nothing to do with 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 your CPVT. I just saw a note fly through of somebody had a life-saving SICD shock. Um, and I passed over it already. So if that's the case, oh yeah, Jason, last week from the ICD device. And as you know, last week we had a session with my good friend, or 2 weeks ago today, with my dear friend, Dr. Charlie Barul out of Washington, D.C., about defibrillator and defibrillator technology. And so absolutely, those patients of mine who need a defibrillator, there have been some life-saving shocks. But to date, there's never been a patient of mine without a defibrillator who wished they would have had a defibrillator. So I'm glad you had yours. There was obviously good reason for yours, Jason, and it did what it was meant to do. And I'm going to give Brianna, the last question about children returning to school. And Brianna, by the way, on your Twitter, I love the picture of the horse's tongue. Made me laugh this morning, so I enjoyed that one. But this, Brenda, I think we will. The real answer on the returning to children to school is going to be, it depends. I'll throw out a prediction. If we're starting to have 100,000 cases per day, we're not going to be returning to much. There will be a change in the return to school in the fall. We have got to get a handle on the number of cases mounting each day in the United States. So everybody, game face on. Here is game face out in the public square. Do it. Put it on. Tell others to have it on. This should be a universal recommendation. Um, it doesn't have to be the red pill, blue pill phenomenon. It should be universal. Wash your hands, stay physically distanced. If we see that number come back down to 40, 30,000 cases a day, remember 1 month ago, catch this, everyone, June 9th, I looked it up. The number of cases on June 9th was 18,000. We were sub 20,000 cases for about a 2-3 month stretch. The last 3 days in a row, we've been at or above 60,000 cases, and we set the record yesterday in the United States. Let's set records for something different. How about a record like I walked through the grocery store and 90% plus had on a mask? Or, and I can tell you, if you come into Mayo Clinic, you won't see somebody without a mask. It is a 100% I mask, you mask, we all mask together. So, Brianna, let's stay tuned on that one about back to school strategies, because I think we're going to need to see what trajectory are we on. Are we next week? Will we be saying there were 70,000 cases, or by next Friday do we say that there were 50,000? We're seeing a downtick. It really is going to depend on which is the direction that we're heading, because the last 2-week trajectory has been disappointing and concerning, and I think all bets are off regarding how we will be doing school in the fall. Well, I could do this for another hour because the questions are that good. Next week, come back because we're going to do it a little bit different. It's going to be a lot of fun. I'm going to be joined by the vice president of our SADS board, Dr. Susan Etheridge from Salt Lake City, Utah. She and I have been, let's say Batman and Wonder Woman for the last, many years together. And it's been wonderful getting to be her sidekick. And so she's going to join me. And we're going to take, the SADS Foundation has been putting together over the last decade the 10 most often asked questions that you have had. And we're going to do it David Letterman style, starting with number 10 and work our way back over the 40 minutes plus to the single most asked or most concerned about question. That's next week. So come back July 17th, same time, same SADS Facebook Live channel. Then I'm going to keep it a secret. 2 weeks, it's going to be really cool. If it ends up being just me, that's not what I meant. That will have meant that I tried and I couldn't reserve the particular person that I'm working on. Not that I'm really cool. So just to be sure on that. So try for that. But for sure, we'll round out July 3 weeks from today, July 31st, an earlier start time, 11 a.m. Central Standard Time, 11:20. With Dr. Peter Schwartz from Italy. I am going to love taking the 40 minutes or so to interview Peter and have him walk through his past, present, and the future as he hopes it is with respect to our families with genetic heart conditions. So until next week, I do hope all of you stay corona-free. It still is a really low chance of getting it. Do everything you can to make that low chance zero by doing all the things we said. And I didn't show you this last week, so I'm going to now. There was my granddaughter, Jaden, 4th of July. And I'm going to see her again in 4.5 hours. But who's counting? So until then, take care, everyone. And on behalf of the SADS Foundation and my CEO and boss, Alice, Laura, thanks for choosing to join us. Stay well, everyone. Stay safe, and blessings to you all.